Anyway, we are live. Hi. And this is episode 1, season 1 of Fire Your Doctor with my wife, Dr. Danielle Lockwood.
Yes, and my husband.
Yes.
My husband, Richard Lockwood.
Hi there.
Hi.
So let's just get into it. What is Fire Your Doctor?
Well, Fire Your Doctor really was originally started as all these thoughts in my head about, I'm a naturopathic physician, I'm an acupuncturist, my background is, as a dental hygienist. I had all these ideas about how medicine was supposed to be and how God naturally put us together and how it's become so unaligned with the way that the world is with medicine. And so in February of 2020, I just really felt the call on my heart to sit down and start writing these thoughts down. And I didn't even have a title for the book, actually. It became a book, which by the time this podcast goes out, the book will be released. So the book is the same name as the podcast, which is Fire Your Doctor. But yeah, it really was just words and thoughts from practice and sort of getting my heart out to hearing mainstream talk about how healing actually happens and what I've actually experienced as a doctor, and just years and years, at this point, decades of research and experience working with people and knowing what it takes to heal.
Okay, awesome. So let's see. Can you give me, so we've got people listening from all walks of life and all different kind of perspectives. We've got some people that are like Alex Jones, tinfoil hat, the moon landing was fake. We have other people that are like, hey, listen, I work in the emergency room every single day. I'm putting in overtime, night shift, saving lives. What do you mean fire your doctor? So can you give us like kind of a middle of the road mainstream example of like a way that, say, pharmaceuticals or just like the system that doctors are operating in, how is that letting patients down?
Well, number one, I think, when our grandparents grew up and when our parents grew up, it just was the doctor, was pretty much God. It's like if the doctor said it, that's just what it was. And the way that I learned medicine was the doctor's more of a teacher and it's more of a conversation. And something I say to my patients all the time is, you live with you all the time. You're experiencing what it's like to live in your body. What's really going on? Let's partner with each other. Let's work it out. But the system really is set up, the conventional system is set up to just go in and, make it happen. Just do what the doctor says. These are our protocols, or this is what the hospital protocol is, right? It's really the art of the doctor, and the art of the doctor trying to figure out a decision has been taken away from them. So Fire Your Doctor is a call to action to patients, really to say that you have informed consent and you can work with whoever you want to work with. But it's also a call to action to doctors who know and feel that they wanted to get into this art of medicine to really helping people and feeling like they have to practice with their hands tied behind their back. Who's tying their hands? Usually the hospital system, the insurance companies. We talk about that really deeply in the book too, is that we're, to use your word, which is a biblical word, the Leviathan of the hospital system, and not only the hospitals themselves, but to the shareholders of the hospital too, right? These are publicly traded companies at this point, which is very interesting since they are also set up as nonprofits, right? So it's, Kaiser Permanente is a nonprofit, like Providence is a nonprofit. However, they also have
$1 billion
nonprofits where their, mission, when you read their mission statement, it's so good. But when you're actually getting into it and experiencing it from a patient perspective or from a family perspective, you're just there scared and want the best treatment possible.
So, obviously I've read the book.
You helped write the book.
Well, I mean, anyway, no, but let's pretend I haven't.
Yeah.
Or let's pretend I'm just getting into this. And let's pretend I'm having more of like a hospital background, more of like, hey, listen, I went to school, they taught me about this stuff. And like, now you're taking away my antacids, like stuff like that. Let's give some people some easy examples of like ways that this kind of cookie cutter medicine, how's that affecting them, and why is it? What's wrong with it?
Well, humans are not a one size fits all. I think that's really important to establish. When people come into our clinic, the first thing I will say to them is, number one, I believe what you're saying. Number two, I might have an idea of, treating somebody with similar symptoms to you, but ultimately everybody has an individual protocol. We might have protocol ideas, but every individual needs to be treated. You need to treat the individual in front of you. Otherwise, you're not going to get the results. The other thing I would say is, even to hospital doctors, let's say it's an ER surgeon, somebody who's dealing with trauma all the time. Yes, body parts are the same, but they're also a little bit different. And the way that they have to adjust on that scene requires an instinct, requires an art, requires an intuition, right? And that's being taken out. Many of the people who are coming in aren't coming in for an emergency. They're coming in with chronic disease,
Okay.
And so we need to reframe how we're treating people based on what kind of illnesses we're dealing with in society right now. So it requires a lot more relationship. It requires a lot more education, and it requires a little bit more time to investigate what's actually happened along the way.
I guess what I'm looking for is, like, we're seeing a lot of these medications just very commonly prescribed. Let me see, statins, antacids, like things like this. And it's like, if you just kind of came at that and just told somebody that, in the mainstream, they'd just be like, well, you're crazy. Of course you need a statin. Of course you need an antacid and stuff. And I guess, like, just give us just pick something that you could use as almost like a case study for us. Not a specific person, but just like a case study, like, this is what the hospital's doing, or this is what the mainstream medicine system is doing. And like, how's that not serving people?
I feel like mainstream doctors are really working with a very limited mindset and a limited toolbox, right? They are either trying to distinguish if somebody needs a drug or somebody needs surgery, because that is how insurance pay out. It's being dictated by payouts from insurance. Counseling is not being reimbursed as high as prescribing a medication. So,
what do you mean by counseling?
Nutrition counseling, what it's actually going to take for somebody to heal from the reason why they have that acid reflux in the first place. So you're always wanting to ask that question, why? And that's been taken out in a 5-minute or 3-minute visit in an urgent care or in a primary care office. You're not going to have time to really know the why. You're going to, okay, yep, antacid, great, here's your choices.
So in the book, and you talk about some kind of physiology where somebody might have low acid, someone actually is complaining of acid reflux, and their response is, I have too much acid in my stomach. It's, I'm starting to get acid reflux, maybe GERD, stuff like that. I'm going to eat a bunch of Tums, or I'm going to take like a proton pump inhibitor, something like that. Whereas you are going almost like the exact opposite and saying, no, I want to increase their stomach acid via supplements and other like changes. So explain to me why I'm getting acid in my throat, and my solution is that I actually need more stomach acid, not less.
Yeah. So we have to really understand the human body in order to answer that question. So one of the things I would say is, one of the top reasons why people get acid reflux is they have chronic digestive issues that aren't being digested correctly. They have chronic issues with overeating, which causes distension.
That's not my problem.
Which causes distension in the stomach, which then shuts off the upper digestive system and makes it think it's full when it's not. And so we're seeing a misfiring of stomach acid not a low amount, like not an overabundance of stomach acid. So in the sense, we don't have enough stomach acid when we need to digest the food, and we have too much stomach acid when we're laying in bed 2 hours later.
Okay.
And that's only one piece of it. Like there's also structural things. There's also, you've gained weight in your middle section.
I have not.
I'm not naming names, but
I have gained
you in the general population have gained weight.
We don't want to say anything.
Exactly. Have gained weight in the middle section, and now you're wearing pants that are too tight, which are pushing your belly upward. And we can talk about this when we go over that chapter, because I think one thing that I'd like to do is use this podcast as a deeper discussion of each of those topics, because there's so much more to say. As we were writing the book,
we'll revisit this.
I know. As we were writing the book, we're like, we could make an entire book just about this chapter right here, right? And I said, well, I think that would be great content for discussion, and that way we can open it up to, the comment section and just different people asking questions about it, because we've been writing this book since 2020, and we've been writing it in sort of an echo chamber, right? It's like you and I have been batting these ideas back and forth to each other, and yes, I get to talk to my patients about this stuff, right? But it's also important to take it to that larger audience and figure out, well, what questions do you have? Because at the end of the day, you're not a doctor, but you pretty much almost could be at this point, just because you hear me talk all the time. And you've also... I'm
just a really big fly on a really big wall.
Yes. And also you've written so much content, in my voice and taken ideas and it's really we've been a team collaborating behind the scenes, which...
You're very kind.
Yes, which actually my patients know about, because they hear about that all the time. Wow. I'm always like, oh, yes, I do write things, but Rich makes it very pretty.
I try to.
Yeah. So I think...
Blame the typos on me. It's my fault.
Yeah, but I think it's just that idea of the why. It's not a one why. It's like, oh, you have acid reflux, and that means you have low stomach acid. Yeah, sometimes it does. Or sometimes it means the acid's getting trapped physically because your stomach needs to be, put in the correct position.
My pants fit just fine. Okay, listen, let's... Yeah, but that makes sense. It's like, hey, listen, we gotta get this together. Okay, put these on, and then we're gonna be good to go.
Well, it's the nature of the posture too. I want to talk about it when we're talking about that episode.
Okay, we can get into that more.
Yeah, we can get into it.
I just I feel like this stuff, we can talk in generalities and things like that, but we are dealing with just a generation that seems to just have this wider sense that we've just been lied to. Mm-hmm. And so it's like, and even in a lot of the natural health safe, God bless all of them, but it still seems like we're just kind of getting into these, just kind of the same old thing, like you once told me, it's time to retire the phrase root cause.
Yes. It's very, and even in my profession, it's been marketed and it's been overstated and it's been, diluted, and it's been co-opted, by other doctors who think that they could just step in and replace, instead of, I don't give out antacids, but I give out these herbs that inhibit the acid flow. And it's just like, we call that green allopathy. It's like, you're just trying to put a bow on your same philosophy. We're dealing with a philosophy crisis.
I'm going to go eat the diet that you would get at, let's say, a fair, like chili dogs and whatever, and then just take some supplements and cover that up and wonder why I have acid reflux.
Well, as you hear me say, and you'll hear me say it so much more, nobody's having an antacid deficiency. I
was fishing for that one earlier.
You weren't born with a Tylenol deficiency. You weren't born with an ibuprofen deficiency. This isn't a mineral that is necessary for normal processes happening in the body. What's that?
I do think I actually have a corn syrup deficiency. It's I'm teasing her. This is not real.
I think you just want to get me all fired up. But you can't fire this doctor. You're married to her.
Oh yeah. No, off camera she's gonna tell me about it. No. No, this is good. This is good. Let's see. So what's the hope? Like if you're a physician, you're a nurse, you're a caregiver, like anywhere in that like healthcare continuum, like what can we do? Like what do we do? How do we fix this?
Well, number one, I think for me, even when I was in medical school, it was so hopeful that I witnessed cases that seemed hopeless go to cure, that we actually saw people get better and we saw that the medicine worked. So I think number one, this book is full of case studies of, our patients at our practice where we've taken them from these extreme complicated situations and we've reintegrated their body back to have normal functions. And then on a side from that is, as a doc, a lot of times we don't even know what normal is. We know what common is.
Ooh, this is a fun topic, actually.
Yeah, we know what...
Are you talking about like lab results and like sampling bias?
I mean, yes, absolutely. We don't even know what normal is. I mean, we think we know what normal is. What we know, what we are actually experiencing is what is commonly seen.
Common, yeah, right. Because somebody that's like, I just crushed a 5K, I feel great, marriage is great, sex life is awesome. That guy isn't just going in to see his PCP every month.
Correct, yeah. And I do realize at our clinic, we're also seeing people who have gotten so bad that they're willing to come and spend the time and pay out of pocket to come and see us to help them organize the chaos that is their health.
Right. So even we would have a sampling bias because we don't see the thyroid problems that aren't there.
Yeah.
Okay.
So teaching patients, going back to doctor as teacher, is just so important because not only am I trying to teach my colleagues, even my conventional medicine colleagues, hey, this is possible. Well, what do you mean it's possible? Yeah, it's possible. And what is the idea of remission? Is remission you're on a drug for the rest of your life and that's just it forever and ever, amen?
It's good for somebody.
Right? Or is remission no drugs, completely your body is back to a functional system and I've had health in all these different areas. And I think that's the other thing to talk about is what is health? Right? What is wellness, right? So health, the definition of health is the absence of disease, but that's not thriving.
Right.
So we talk about that in the book too. It's like, let's redefine that. We're not just after health, we're after wellness, right? Wellness is a state of balance within multiple areas of your life that make you a full person in the world.
So there would be an element of, say, like empowerment within that. Like I could be cancer-free, diabetes-free on the couch, but I do not have the power, mental, physical, spiritual, like emotional, to just like get up and start a new business, go take all this acreage that we're looking at and make it into a functioning farm. That's more like what you mean. Yeah.
Ultimately, what we're after with patients who come through our practice is to set the captives free. Really, we want to set them free. And that requires patients to understand that it's not a physical walk. It is that. It's not a biochemical walk. It's that. It's not a mental walk. It's that too. It's a spiritual walk. It's all of them. And you have to walk out all of them. And seeing your illness as maybe the call that you've needed to wake you up to getting fulfillment in your life.
I have this vision that kind of goes with that. It's actually a Bible verse, and I forget the chapter and verse. You guys can look it up or just Google it. Blessed is the teacher of the law who is also part of the kingdom of heaven, for he will bring out of his storehouse treasures new and old. And how that applies to this is what I want to see is I want to see these doctors that are more in this mainstream I want to see them kind of come out of that, but take everything that they've learned with them. And so somebody that is empowered is this, like, I'm an ER doctor and I have saved hundreds of lives, you know, and just this type of thing. But then also let's underpin that with these concepts of, like, say, functional medicine and these deeper ideas about how do we break the stranglehold of insurance?
Yes, I mean, really, that's what it's about, and breaking free from that, but also being able to provide it in a way that's attainable to people, you know?
Right.
Because that's the thing we run into as well is, okay, well, we're out of this insurance system, and how do we provide care for people?
That's been one of the harder things to explain in clinic to people, because they're like, oh, no, I don't want these labs. I'm going to get my labs through my insurance because I'll just pay the copay. But a lot of the times what we're seeing is that when they do go through their insurance, just that all the added inefficiency makes their copay higher than the cash price that we've negotiated.
Absolutely. Yeah. And then trying to explain that in 2 seconds while you're trying to just, you know, help them on that healing journey.
Let's break your entire paradigm right here.
Yeah.
Your insurance is costing you more and providing you less than if you just went out and bought it cash. Yes. Not always true, but there's a lot of cases, especially in labs and diagnostics, where that is, we have found that.
But there's this purposeful system where things are being held into these ivory towers where you can't see what the insurance prices are, and the doc doesn't know, and this fee works sometimes, or this code works sometimes, but add this code so the insurance, it's just like this secret.
Left or right.
Yeah. And we actually talk about this in the first chapter of the book. It's like, there's no other company that I can think of where you go and they have you have a visit and tell you, we'll pay you a couple weeks later. What's the cost? I don't know. Oh. And you're supposed to just be okay with that.
No, wait, I got one.
Yeah.
I got one. Let's brand this. Purposeful opacity.
Ooh, I like that.
I don't know.
Yeah.
It's a purposeful opacity. I'm just playing with it. Let's talk about something else, like something that kind of came to me. We've talked about it before, but you reminded me of it in this conversation. We were talking about, like, the names of some of these hospitals and, like, their nonprofits, and we've mentioned a couple, like, you know, we mentioned God here and there in this.
Yeah.
Let's talk about some of these hospital names. Legacy Emmanuel, Providence, what is it? Adventist was another one. Good Samaritan. And it just seems to go on, but, like, let's talk more about the emotional and, like, the spiritual state of our hospital system. Like, where were we and where are we now?
That's a really big question.
Just wrap.
I don't think I'd be, and I want to just say, I am not the expert on every single one of these things. I have opinions. I have experience, speaking with other patients. I have my own experience dealing with the hospital systems, with myself, with family, things like that. So I'm by no means the expert on this. However, from what I can observe from those experiences, plus from the research that I've done, we're watching the corruption of a really godly, service to people, right? Healing people. We have with the Catholic Church, nuns that their entire world and their entire life is dedicated to God and serving people and healing them. There's a really great book, actually, God's Hotel. I think it's actually behind me. Victoria's Suite, God's Hotel. Really awesome book based on the experience of the last free hospital that was truly a nonprofit hospital outside of San Francisco. And her experience with being a doc. She graduated in the 80s, so I think it shut down in the late 80s.
It's too bad.
And it was truly run as a nonprofit, and their focus was on saving money, but also getting people well and dealing with their spiritual selves. And she coined a term, which I use a lot, and I love it so much. It's called slow medicine.
I didn't know that was from there.
Yeah, the slow medicine is from that book, but she really, speaks of how the nonprofit had been co-opted by the Medicare, Medicaid systems, and everything at that point switched over, and it became about the coding and the system and the government's hand ultimately in the care, even though in her opinion, it was like, well, this is actually going to save us money by doing this the right way, as opposed to this person's just going to be back in a week. Right. But to go full circle on that, it's just like, that was the same thing that happened with, for example, you know, some of these larger hospital systems where it started out as a nun order, right?
Okay.
And God was in it, and it was about the holiness of obeying the commandments that are most important to Jesus, which were love God and love people, right? And so they really felt that it was a service of their spiritual walk with God to help people and heal people. And as they started to grow and need more profit and insurances started to get involved, that's when we started to see that corruption and that seed being laid. So, you know, we could get into that as a demonic control, or we could talk about it from that spiritual aspect. But historically, yes, most of these hospitals were originally part of the church system.
Yeah, I guess that's kind of what I'm getting at. That's a good answer. I think that what you talked about was really important. Like when we're thinking, like in, say, philosophy, or in like, you know, just like looking at the meanings of words and like stuff like that, the way that we define, the words that we use have just such a tremendous impact on our thinking. And so it reminds me of the book of John, where it's like, in the beginning was the word. But that's another story. Where I'm going is that what it sounds like is these insurance codes and this need to kind of like pinpoint and codify everything, and that an insurance company will only pay for these very kind of predefined issues. It actually starts to limit the way that doctors are allowed to think about patients' problems. Like, and that's fine if it's like, you stubbed your toe and now it is broken. And then we can define that. Okay, this code, ICD-9, ICD-10, whatever. And all right, we can really pinpoint that. But, you know, how would you deal with an autoimmune disorder in that?
Oh, that's an entire forms.
Book 2.
You know, yeah, like the mainstream medicine system, the MD system, let's just say that. And I don't agree on autoimmune disease. But I have seen autoimmune disease reverse in my office, and I've rarely seen it reverse in a conventional system. And again, it's not because they don't want to, it's because their philosophy changes with the insurance coding. So their philosophy is so intrinsically tied to the insurance code that it changes with the wind. My philosophy of care does not change. It is steady. It is steady. It is observing the human body and knowing what normal human bodies are supposed to do and bringing that human body back to center.
I might push back on that a little bit and say that it's the insurance model that is like not changing with kind of like with the patient. Like it's like, no, you will fit into this box and I'm going to cram you in here even if you don't fit.
That is absolutely true, but I would say what's dictating standard of care within conventional systems moves with how insurance covers things.
Okay, no, yeah. I would say that, yeah. But the problem is that insurance coverage and things like that are going to by nature be like kind of driving, looking in the rearview mirror, because they're going to look at, well, what were our costs, say in the last like quarter or the last year or 5 years, whenever they're kind of, you know, reevaluating things. And so that, to me, it would really create a system that's unable to deal with anything that's outside of what they already know.
Correct. And they're used to, and because,
2020.
right, exactly. Because the hospital system is set up in a way to they practice top-down medicine, right? They don't practice horizontally. They practice vertically in the sense of there's an order that comes, can't see my hand, but it's here. Yeah, there's an order that comes from the shareholders, which comes from the board, which goes down to the directors, which comes down to the managers, which then goes to the charge nurse, which, you know what I mean? Like,
Right.
I don't know the exact system of that because I've never worked in that hospital system.
DNS, Director of Nursing Services.
Exactly. So there's this hierarchy, very much like a military, right?
Yeah.
Which creates efficiency, but it also creates a bloated bureaucracy. And this actually was very highlighted during the pandemic because it made it so, well, okay, I'm finding these things on the ground that are working for this patient. And then as a doctor who's just, you know what, I'm just trying to save people's lives. That's where my heart is. But then coming by and getting your hand slapped by the director of nursing or nope, we're not doing that anymore. But it's
Right.
actually working and it's cheap and it's an off-label use of a drug that we already have and we can get it readily. Nope, it's ventilators. That's what we're doing.
Yeah.
Right.
Yeah. We saw a lot of that in the pandemic.
So it's medicine by managerial decisions. Like,
Right.
I don't know what to call that. It's medicine by group medicine. I don't know. It's not. It's taking the
I'll tell you
individual.
what it is.
What is it?
What do you call a government structure underpinned by corporate interest?
Fascism.
Oh. Okay. Yeah. And in a way,
I felt like it was Jeopardy. I'm like, what is fascism?
Yeah.
Yeah.
Fascism is anything I don't like. Like, it's like
Yeah, it is. And
I'm kidding.
And instead of making it from a dictator, I'm going to make it from a private corporation
Right.
that's intertwined. And so that's what we're seeing with medicine. Our medicine has been so intertwined with our government, and it's been so intertwined with these large bloated corporations
Right.
that the art, like, there is no time for slow medicine. There is no time for these things. Like, I think individual doctors and nurses got into medicine because they wanted to help people. I believe
absolutely,
that.
yeah.
I absolutely believe that. I have friends who are from that world. We can agree to disagree on some things, but ultimately, I know they love people.
Yeah.
You know, I know that they want to help people, but they have become so jaded by a system that's telling them how to think.
You know, one of the things that's really interesting, though, is it seems like what you're saying is that, and we saw this in the pandemic, like plenty of examples of really just kind of autocratic, top-down, basically the medical decisions for the entire country were being made by doctors that hadn't seen a patient in 20 years, 30 years, 40 years, or even kind of ever.
Yeah.
And that there was a disconnect between the doctors at the top or the policy leaders at the top and the actual doctors at the front line treating bedside that are like, hey, wait a minute, if we did this, if we did that, you know, say just oxygen supplementation versus pressurized ventilators and different outcomes in there. There's a lot of good research. But you could also go the other way where we have, let's just say, physicians that are acting maybe too rogue or something like that, and there isn't kind of a structure or an order. So it's, in some way, I think you could make an argument for some kind of order, some kind of standard of care,
Yep.
but it would also have enough flexibility to allow innovation.
And we were talking about this too, because one of the things that we ran into was because of the quote standard of care that's happening, we were held to something as naturopathic doctors that maybe we shouldn't have been held to, because what is our standard of care, right? What's our standard of care? Our standard of care is to follow the nature of the body and to figure out what's best for that individual, right? However, the way that the board judges you, like, for example, the medical board would judge you would be based on, well, what are typical doctors in your area doing? And so there was just this fear amongst doctors, even though we saw the evidence before our eyes that these certain procedures were working better, there was so much fear within us to go outside of that standard of care in order to keep in line with what everybody else was doing. Because if you happen to go outside of that standard of care and somebody died or got hurt or whatever, then you lost that protection, and you would also then face the consequence of the board.
Or even if the wrong person complained on Facebook.
Or if, or you know, and that is actually,
I mean, social media. We're not naming names.
Yeah, exactly. and that's the other thing. It's like now what, social media is the one that can take away your license that took you 22 years to get?
Yeah.
Like, you know, because you didn't like that I said God, or that you didn't like that I, you know, was willing to use herbs or willing to use these things that I was seeing working. Like what, you know, who gets to determine that? You know, who has the right to determine that?
Yeah. And we definitely saw during the last 5 years like a big shift towards centralized power and control within medicine, and I would say to the harm of patients everywhere.
Yeah, I don't really know what the answer is. I would love to hear some comments on how can we reform that, because I had people who were in conventional systems wanting to help patients but feeling like they couldn't because their board would slap them on the wrist for it.
Oh, slap them on the wrist and
take
handcuffs.
Away their license,
yeah,
you know, whatever.
Like,
I mean, I'm friends with some of these people, so I understand that's what it is. What is the solution? Because I agree with you. Like, we can't just have people like, you know, I heard gasoline's really good. We should put that in an IV. Like, no, terrible idea. Do not do that. Like, awful. So yes, we absolutely.
We're going to brand it as an energy drink.
Yeah, we absolutely need to have a standard of care. We don't, you know, need to be, you know.
Yeah. Well, I think it's like
trying things.
I think it would be like let's look at it like a healthy body. It's like we want semi-permeable membranes. You know, we want membranes that can push out waste. They can let in nutrients, but they can also protect from, say, like pathogens. So it's like, and this is always easier said than done. But let me see, there was one more thing.
Well, we use that analogy a lot, and this is actually one of the reasons that I married Richard, is because I can say things like semi-permeable membranes, and
phospholipid bilayer.
He knows what I'm talking about, because this is the way I express love in nerd science information.
Well, yeah,
but I would say yes, and that's also a tool that we use to explain healthy boundaries when we're talking about healthy boundaries instead of walls. Like, but that's for another episode.
Yeah. Well, I mean, it's also, when you get into phospholipid bilayers, you get into the importance of cholesterol.
Yeah.
Lipitor.
Yes, next. I'm after you, statins. Yeah.
Well,
so, yeah.
Welcome to the podcast. Welcome to Fire Your Doctor. We are here to introduce the world to my lovely wife, Dr. Danielle Lockwood. And, you know, thanks for being here.
Yeah, thanks for interviewing me, and thanks for going on this journey with me.
Yeah. I have thoughts.
I have some thoughts.
Yeah. Oh, well. Yeah. Anyway, it's been fun. We should get together soon.
We will. We will.
All right.
Bye.
Bye.